My name is Fred Osher. I'm the Director of Health Systems and Services Policy at the Council State Government's Justice Center, and I'd like to add my welcome to the many others that you've received and my thanks again for the work that you do. I have a chance to spend the next hour with you thinking about those individuals within your programs that have behavioral health needs. And when I use the term behavioral health, I'm implying alcohol, drug, and or mental disorders, and they come in all sorts of combinations. Through the course of this discussion, I'll be amplifying the mental health side of the equation a bit, and that there are a number of sessions here, and I hope you'll attend them, that focus on some of the practices associated with good outcomes for those individuals with substance use disorders. As you know, the Council State Governments has three components. We're here working on the center of that and really the heart of our work. But I wanted to just take a moment and share with you some of the work that exists within the criminal justice and behavioral health area. We started in 2002 with the release of the Consensus Project report, document that represented the bright ideas of 300 to 400 people that participated in it. It's 10 years old, but the policy recommendations are still very relevant to improving outcomes for individuals with mental illnesses going through the criminal justice systems. We have other grant programs that we have the opportunity to provide TA for, including our Justice and Mental Health Collaboration Program, and I'll be referencing that at a couple different points during this discussion. We put out documents. They're for display on our table outside, but also on your thumb drives, and I encourage you to take a look at some of these materials as they provided touchstones to some of the critical issues that are barriers to people moving forward in their recovery. We have curricula that are being developed to assist those individuals with a special interest in working with this population. We have the ever-present webinar, and if you have a chance to participate in those, you're invited. We really welcome your participation. And again, a newsletter that focuses on the interface between mental health and criminal justice. There's a sign-up sheet outside for you, and if you'd like to receive this electronic newsletter, please do so. What I want to do today is provide an overview of mental illness in the criminal justice system, as well as substance use disorders, to talk a bit more about target population and the risk-need-responsivity model. If you haven't heard enough about it, I'm going to talk a little bit about how it gets integrated into the work that you do and we all do with folks with behavioral disorders. I want to describe briefly some of the comprehensive and effective services that are associated with good outcomes for this population, and then have time for question and answers and not delay you from lunch. This is the phenomena that brings us here, and we're all well aware of it. An expanding population under correctional supervision. The largest wedge of that is the community corrections population, almost 4 million. On parole, another 800,000+ in our prisons, over almost 2 million, and in our jails, 780,000. And this is not a random sample of our U.S. population. It's why I have an opportunity to talk with you today. There's an overrepresentation of certain groups, particularly with behavioral disorders. We have 5% of the world's population, about 23% of the world's prisoners, and so there are many people coming out and many people for you to work with. We have had this increase over 30 years in our state prison population, but the good news is the first time in 38 years we've seen a decrease. Would like to think it's causally related to your work. Why not? Let's take credit for it and see if we can continue that trend in bending that curve. There are substantially higher rates under correctional supervision depending on demographics. We have adults about 1 in 31 at this point in time. If you're a woman, about 1 in 89. Men, about 1 in 18. Black males, 1 in 11. The population that is now being brought into our correctional facilities have changed, and this diversity is something we need to account for as we think about culturally sensitive and effective responses to the population that is inside and coming out. We have a growing number of women in our correctional facilities. The yellow bar are women in federal prisons, the yellow component of the bar, the blue, those within state prison. We have a lot of individuals that get there in part because of their substance use disorders. And within jails, it's estimated that about 50% meet criteria for an alcohol and or drug use disorder. In our prisons, it's a similar percentage, and that is about 25 times the rates of substance use in the general population. But it may be why we have an hour to spend together. The majority of individuals will have either an alcohol and or drug use disorder coupled with mental illness that you're working with, and we need to understand how to be responsive to those particular circumstances if we're going to bend that curve. The number of people in prisons and jails for drug offenses, and this is looking at 1980 compared to 2010. It's state prisoners on the left, it's federal prisons in the middle, and jails on the right side of the slide. And we see this dramatic increase in individuals that are in those settings related to drug offenses. And then many of them also will have drug use disorders, which complicates their recovery and their integration back into our communities. So too is serious mental illness overrepresented within our correctional settings. This slide is the summary slide of a study we conducted a few years ago. 2 jails in Maryland, 3 in New York, over 20,000 individuals that were booked, screened for mental illness, and then assessed for the type of mental illness. And this slide represents those that met criteria for serious mental illness. And we can talk more about the distinctions between less serious, serious, and severe as we go forward. But I think the important point that I want to make on this is compared to the general population, we have 4 to 8 times as many folks in our correctional settings under correctional supervision that have serious mental illnesses. And I think one of the important points of this slide is that while 15% of men met criteria on booking, 31% of women booked into these jails met criteria for a serious mental illness. And, as I'll show with some slides later, there's a concentration effect. That is, if you look at the average daily population, not the booked population, the folks that sort of spin out in the first 24, 72 hours, they're not as many that have serious mental illness, so that our jail population and prevalence numbers are actually higher than these. These are high enough, and that we need to understand, in part, the pathways in that explains this phenomena, because that can help us in design pathways out. Of those individuals within the facilities that met criteria for serious mental illness, 3/4 of them also have a co-occurring substance use disorder. And I'll talk a little bit more about co-occurring disorders, and that it is a complicating feature. Having both disorders is not just twice as hard as having one or the other, but multiple factors hard for a variety of reasons. And it's associated with all sorts of morbidity and mortality, co-occurring disorders. And it represents a large segment of the population that you're working with if you're selecting the target population that we've been encouraging you to over these last days. This is all occurring, and I don't need to remind any of you this, at a time of increasing pressure on our budgets at the state level, so that the recession has created difficulties in balancing budgets and necessitated cuts in a variety of places. In Camden, New Jersey, a year ago, the headline was police force cut nearly in half, and it was effective immediately. Here's a headline from San Mateo where the jail has just signed a contract for mental health services for $1.7 million with a provider at the same time that the county pulled $49 million out of its behavioral health budget in the community. State prisons, the cuts present new problems. Justin Jones, one of our leaders in corrections, quote, "We have no drug treatment programs at medium security or above facilities. We eliminated all sex offender treatment, even though it was mandated by statute." Probation officers hit by statewide budget cuts. In this, we have nearly 2 to 3 times the caseloads for those probation officers than they had previously, making their work extremely difficult. And for you probation officers in the audience, thank you for the work you do under these tough circumstances. It's so disappointing to think we might be going backwards, is a quote from this probation administrator. We've had cuts to our behavioral health services. The block grant, which is the principal funding mechanism for public services for folks with substance-related disorders, has experienced declines from years 2004 through 2008, In a 2000 survey, the National Survey of Drug Use in Household, it was estimated that 23 million Americans aged 12 or older were in need of an alcohol or illicit drug program, but only 2.6 million received treatment that year. So there's a significant gap between our capacity and need, making it all that more important to think about how do we use our resources as efficiently and as effectively as possible. This is a survey that was conducted by the National Association for State Mental Health Program Directors, and surveyed states and asked them where were their cuts occurring in response to their budget deficits. The lines represent fiscal year 10 and fiscal year 11. I'll draw your attention to the bottom of this chart, in which state acute inpatient and short long-term inpatient beds were the most frequently cut services. And all of you that work within communities know how hard it can be to access a psychiatric bed when somebody is in crisis. So that was sort of a nice downing introduction to things. And I know you didn't need to be reminded of how tough it is at home, but it is tough. We're aware of that. And nonetheless, we have some things that we can do. The problem and why folks are overrepresented within our behavioral populations is multiple. They obviously are arrested at higher rates, or they wouldn't be there. And a lot of that has to do with the drug data that I showed you earlier and the co-occurrence of substance-related disorders in individuals that have serious mental illness. If I have a serious mental illness, I'm 3 times more likely to have a substance use disorder. If I have a substance use disorder, I'm 4 times more likely to have a co-occurring mental illness than the general population. It is also the case that homelessness is an explanatory factor. We have an affordable housing problem in this country. 2 million people this year won't sleep in an adequate shelter, about 800,000 tonight. And the homeless person is a very visible person. So I worked in community psychiatry in Baltimore. In February, when the temperature was predicted to go below 0, the code blue shelters open up. Everyone's encouraged to go inside to avoid hypothermia, which is a real consequence of exposure to those elements. And some people go and some people don't. Law enforcement encounters a person on the street, obviously a little bit disturbed, but refusing to go to shelter. They see an open container next to them. They're able to issue a citation. That citation allows them to pick them up and take them to jail. They're off the street. They may have saved a life. Sometimes these are called mercy bookings. But the consequences of that event are fairly profound. That individual likely will be released on their own recognizance the next day or 2. There'll be a court appearance scheduled for 6 or 8 weeks down the road. They won't show up. There'll be a bench warrant issued for failure to appear, and the next time that person has contact on the street for some reason, this will follow them, complicating their entry and exit from correctional settings and starting this revolving door cycle that everyone knows all too well. I want to spend a little bit more time on all of these following points, and I have some slides to illustrate them. I think it's important to recognize that folks with mental illness stay longer in jail and prison, same crime, same sentence, same conviction, but they just don't get out. It may not be the reason why they went into jail, but it certainly complicates their exit for jail, and I'll present some data on that in a minute. The limited access to health care, low utilization of evidence-based practices, high recidivism rates, and criminogenic risk factors are all part of the story. Limited access to health care. We have an awareness that people within correctional supervision under control as correctional agents have serious health problems, but don't often have access to it. We have about 50 million individuals in this country that do not have health insurance at this point. We're all waiting for a Supreme Court decision to understand what aspects of the Affordable Care Act will and won't be implemented that has the potential to bring a large number of individuals that are in correction supervision into the health insured force. It's also the case that poor health access can be explained by some of the stigma and bias that exists. So that you have an individual who people think are pejoratively crazy, or maybe just criminal, or maybe drug addicted, or for the folks that we work with, all of those, that leads to bias, distrust, prejudice, fear, avoidance, distress, anger, and stereotyping, all of which reduces access to a variety of essential services. Housing, we heard about it from our employment panel, treatment, other services. There's a perception of violence that exists for folks that are crazy out in our community, often spawned by the media portrayal of these individuals. I think it's important as a bottom line statement to understand that most people with mental illness are not violent, and most violence in this country is not caused by people with mental illness. And all of this discriminating activity and attitudes leads to difficulties in accessing necessary care and services. We also have the case that even if you get into the door, you're not always getting what science tells you works best. And we have a very robust science in the field of behavioral health. Treatment works. We've demonstrated that over decades of research. But not all treatment is equally effective, and we all know the emphasis that's now being placed on evidence-based practices, which I will emphasize later on as well. I show you this slide because it represents one aspect of this issue, and that is within the National Survey on Drug Use in Households, they call people up and ask a series of questions. Now, they don't call people that are homeless, and they don't call people that are in jail and are in prison, and they don't call people that can't afford cell phones or have no way to communicate. But of those that answer the phone, they can deduce whether they may have a mental illness or a substance use disorder or both. And this pie represents those individuals that answered the survey questions indicating that they had both a mental illness and a substance use disorder. And then the next question posited was, and what kind of treatment did you get in the past year? What you see here is a pie with a large wedge, almost 40%, who said they had no treatment at all, not likely to get better without treatment. Another 45% said they only had mental health treatment. Now, we'll come back to it later, but the evidence-based practice for people that have both a mental illness and a co-occurring disorder is some form of integrated treatment, where you provide support and treatment to both conditions in the same settings simultaneously. So, mental health care only isn't associated with good outcomes for those individuals. A smaller wedge had about 4%, got substance use treatment only, again, not likely to be effective. And then we have that 11+% wedge that's there, and they answered that they had some form of integrated treatment. So I've been following the NSDA for the last 12 years. The good news is that pie wedge, that 11%, has grown from about 3% to now 11%. That's the good news. The bad news is that the majority of people that have co-occurring disorders don't get access to the evidence-based care that would allow them to move forward and quickly in their recovery. So, we also know that folks with mental illness stay longer in jail and prison, same sentence. I've mentioned that earlier. The Bureau of Justice Statistics, 15 months longer in prison, same charges, same sentence if you have a mental illness. They don't do well in those settings. They don't accrue good time. They're often in segregation. They max out at rates higher than the general population. We had a chance to look at a jail in New Hampshire, in Hillsborough. It's also the case that even in a pretrial status and thereafter, they just don't get out as quick. We're looking at those individuals that met a very conservative criteria for serious mental illness compared to those that didn't, bonding out 4 times as long, 35 days on average compared to 9 days if you didn't have a mental illness. Maybe you can't make the bail. Maybe the bail's set too high. Maybe you burnt your bridges to your family so they're not going to post bail for you. Whatever the reason, bonding out takes longer, court ordered takes almost 3 times as long, even just getting to prison takes longer if you have a serious mental illness than those without. And so here you have a concentration effect within our jail and prison settings for those individuals that don't leave. It also is the case, and you all can attest to this better than I, that recidivism rates are high on reentry. And this is a study that was done by Vidal, Manchek, and Scheme. They looked at about 3,000 probationers that had met criteria for serious mental illness. And of interest is that this group, in this study, were no more likely to be arrested, but they were about 1.4 times more likely to be revoked. So they have been in to the court, they've been convicted of a crime, they may not have jail time as part of their sentence, they're put on probation, there are conditions of release, but it's tough to meet those conditions. Might not pay the fine, might not show up, might drop a dirty urine, any of those might result in going back to jail or prison. Our new understanding also is that folks with serious mental illness don't always land there just because of their mental illness. And in this study of over 110 individuals booked into a jail in Hawaii, all of which met criteria for schizophrenia or a schizophrenia spectrum disorder, interviews were done about why did they end up in jail? How did they end up coming to get arrested and being here. It turned out that a small percentage of those, less than 10%, got there in what was sort of defined as a direct cause. And a direct cause would be something like, I have schizophrenia, I have voices, the voices told me to hit the person, I hit the person, I got arrested and taken to jail. A larger group got there related to their co-occurring substance use disorder. Some got there indirectly related to their mental illness. I'm unable to work, I fall out into our homeless population, I get arrested for my high visibility within that community. But the takeaway message from this is that the majority of individuals didn't get to jail because of their mental illness. However, we have now new research that shows that those individuals with serious mental illness have more of the central 8 risk factors, and I'll talk to those in a moment, than people without mental illness. And these are the associated factors that are associated with return to incarcerated settings. So that's given us some new information to think about our targeting of high-risk populations in a more strategic way. The story, we arrest them more often, we stress them while they're incarcerated, we keep them incarcerated longer, our localities face significant budgetary pressures, they don't get access to adequate behavioral health care, they're more likely to fail their community supervision, and so what can you do in your Second Chance Act program? What is the opportunity that you have to slow this revolving door, to ensure that those individuals with behavioral disorders land on their feet in a more likely to succeed way? So I want to now talk a bit more about target population and the R&R model, which you've heard 100 times and 12 times in this conference, but I want to blend it with the behavioral health components. We are talking about criminogenic risk, as Hank in previous panel identified, not crime type, not failure to appear, not sentence or disposition, not custody or security classification. We're talking about how likely is that person to commit a crime or violate conditions of their supervision. We know that those risk measures are composite of static factors, which you can't do anything about, and dynamic factors, which you can. And the static factors include typically these: criminal history, current charges, age at first arrest, current age, gender. But these are the dynamic risk factors that I want to focus on for a moment. And these are the central 8, those that are most often associated with return to custody. Antisocial attitudes, friends and peers, personality patterns, substance abuse, interesting, as a behavioral disorder, a high risk, obviously, with the consequences of illegal activity related to possession, sales, distribution. Problems with family, marital factors, lack of education, poor unemployment history, lack of pro-social leisure activities. Not any one of these in themselves explain the higher risk, but in composite, they do. And I think what's of interest to those that have been working in the behavioral health vineyards for a while is that when I went to medical school and residency, we were taught that personality disorders were chronic and enduring, and that they could not be changed, which was very convenient because when you saw someone that you didn't like, you gave them a diagnosis of a personality disorder, and then you didn't have to do anything. Not so simple, as it turns out, and not very helpful, as we all know. And it is, in fact, possible to change the way people think. And in changing the way they think, change the way they behave. And in changing the way they behave, reduce the risks of coming back into our institutional settings. So these are things that we had as myths before that we need to now more aggressively incorporate it into our toolbox. I will tell you that, and I was at a conference yesterday of one of our grantees, there isn't a lot of this cognitive work in our community mental health settings. But there's a dialogue that's beginning around it, and I'm very encouraged and hopeful that it will become more available. It's one of those evidence-based practices that I'll talk about in a moment that may not be as available as we'd like it to be, but actually has some growth potential at this point in time. Each of those criminogenic risk factors then creates a need, and that need for those that have antisocial behavior is to build alternative behavior, hang with better people, make better decisions, all right? And that the more of these needs that we address, the more likely that individual is to succeed within their communities. I hope folks had a chance to hear Dr. Latessa yesterday. He's been so helpful in our understanding of this issue, and that one of the things I took as an oath of Hippocrates was to do no harm. We actually can do harm if we don't target the right people. This was his study of community correctional facilities in the state of Ohio. They spend a lot of money on those facilities for people that are coming out to assist in their reintegration into communities, and that those as a whole, for individuals that were categorized as high risk, resulted in a 5% decrease in their recidivism. That's good news. The bad news is they didn't take just high-risk individuals into those programs. They also took low and moderate-risk individuals, and they increased their likelihood of returning to jail and prison. That's not a good outcome. That's nothing that I, as a taxpayer, want to spend a whole lot of money to support. So that it's given us the scientific evidence to add to our R&R model and emphasize the focus on high-risk cases. And you've heard that message in a variety of forums, in a variety of settings, and I'm interested in learning from you how you operationalize it. We also want to target those needs, so we have to assess those needs so that we can, not everybody has the same set of needs, the same set of risks, and we want to have an individualized case plan to address them. And then we also want to address this issue of responsivity. And I just want to elaborate on this a little bit because it's very important for our behavioral health group population that you're working with. The responsivity principle says not everybody learns in the same way, not everybody has the same capacities, strengths, and needs. We have to be attentive to learning style, motivation, culture, demographics, their abilities. But this plays out for those individuals with mental illness in the following way. That is a responsivity issue. If I'm depressed and I don't sleep very well and I haven't been eating very well and I've lost a lot of weight, don't have much energy, I don't like getting out of bed, I'm kind of hopeless, I'm not likely to participate well in the anger management group that you run. I probably won't even get there. And if I got there, I wouldn't care about being there and wouldn't learn. You need to treat my depression or help me get treatment for my depression, which may be some combination of talk therapy and medications, but whatever it is, I need to get to a place where I can function at a level to take advantage of the good programming that you have. That's responsivity, okay? It's necessary to address my mental illness, but not sufficient. And that's the distinction we're making as we understand the risk issues. Got to treat it, but treating it alone is not likely to make the difference in recidivism. It's a little bit like the employment answer you heard. Need employment, but employment on its own may not be sufficient. So we're talking about packaging, tailoring, individualizing case plans to address the range of issues that create barriers for individuals to move forward, both in their recovery, but to achieve the public safety outcomes that we all treasure. So there are two critical components. There's target population, and there are comprehensive and effective community-based services. We had an opportunity to apply for a solicitation from the National Institute of Corrections to develop a framework for folks that have mental illness and criminal justice. We were fortunate enough to receive that award at the Justice Center and had an opportunity early on to sit down with project officers and said, you know what? The modal person that comes with a mental illness also comes with a substance use disorder. Let's make this framework about behavioral disorders, not just about mental illness. And so we've embarked, and we're hoping to release later this summer a report. The report drew upon some of the concepts that the field had been working with for a long while. This is probably familiar to some of you. This is a framework for co-occurring disorders, which was developed and vetted by the National Association of State Drug and Alcohol Directors and the National Association of State Mental Health Program Directors, NASDAD and NASHBID. And it's fairly simple. It's a 2x2 design that creates 4 quadrants. On the x-axis, you've got mental illness that go from low severity to high severity, and that's a functional impairment. Let's be clear. Just having a diagnosis doesn't necessarily mean I'm impaired. I can have schizophrenia and be teaching courses at a Midwestern university as a professor, whom I know, or I can have schizophrenia and be out in DuPont Circle sleeping on the bench panhandling. So the diagnosis itself doesn't equate with disability. We have to assess for the severity of the impairment. And so too, from low to high, are our addiction services on the y-axis. This creates then 4 quadrants, and there's no lines between these quadrants because people don't stay in one spot, but it's a heuristic we use for planning. And so if we look at the upper right-hand corner, we call that quadrant 4, and we actually have a dialogue in our communities around quadrant 4 individuals. It took us into a very healthy spot. Previously, the discussions were more like, well, that person is using alcohol. He can't come into my psychiatric program. Or that person's on medications. They're really not going to be participating in our addiction services. And there was this punting back and forth. Well, it turns out that we need to have a more nuanced way of talking about individuals. In this schematic, what we may have in quadrant 4 are individuals with high mental health, high substance abuse needs, and that they probably will do better in a community mental health system that can provide a variety of wraparound services that is typically funded by public dollars like Medicaid and block grants. Alternatively, in quadrant 3, we may have an individual that is opiate dependent but has anxiety disorders that aren't tremendously difficult for that individual, and they can do well within our substance use service delivery settings with some consultation from psychiatry. It starts to get us into a more nuanced discussion about who has what and what they might need and what system should serve them. We used and build on that to to develop a framework for addressing criminal justice populations with behavioral disorders, and again, hope to release this report later on this summer. Here's the algorithm. Here's the way in which we're suggesting people consider correction populations. First and foremost, let's assess need, all right, and then categorize folks. Now, I'm presenting these as dichotomous variables, low and medium high. We know that they exist on a continuum, and where your cutoff scores somewhat depend about what your resources are and what given intervention you're suggesting. But for purposes of our discussion, low needs on the left, high needs on the right. Then, an assessment of their substance use disorder. And substance use disorder can have low severity and high severity. These are very important distinctions, particularly clinical distinctions between people that have abuse disorders and dependence disorders. In dependence, I've lost control, and that I need to access the drug of choice on a regular basis, or I experience problems with withdrawal, and I have a lot of drug-seeking behavior. In the abuse category, I might be able to kind of move forward more quickly into a recovery mode and need less intensive services. So we need an assessment of the severity of their substance use disorder. And following that, an assessment of their mental health condition. Maybe none, maybe less serious, maybe more serious. With that filter, we then describe 8 groups from low to high. And each of these groups have different needs that you would respond to. But when we're thinking about our scarce criminal justice dollars, which get spent on behavioral health, now we all understand when a person comes into jail and in prison that they need to get the treatment and services as a constitutional protection that allows their diseases to stay under control. So risk within institutions is not the issue. Outside of institutions and how we select who we work with, it is. And that we want to make sure that those low-risk individuals aren't chewing up the resources that are needed for the high-risk folks. But wait. I have a low-risk individual that's got a big-time mental illness. Should they get treatment? Absolutely. That's not the issue. But their treatment ought to be paid for by the system that historically is responsible for providing that service, the mental health system within that state. Okay? If you have criminal justice resources to augment those services or purchase some of those services, let's buy them for the groups on the right side of this chart. And that's what this framework is suggesting, and we've got more explanatory narrative around it, but it's fairly simple and straightforward. It does, however, require that you look for these disorders, that you screen when folks come into your settings for behavioral disorders, and if positive, that you assess. So a screen is not an assessment, and we don't want to confuse that. A screen is answering a yes-no question. Might this person have an alcohol or drug use disorder? Yes, no. Might this person have a mental illness? Yes, no. Or both. If the answer to that is yes, then they need to move forward for an assessment to make sure that's the case. We want to make sure our screening instruments are highly sensitive, that is, capture anyone that might have it. We want false positives because we're going to do an assessment to evaluate and move those people out if they don't have that condition. So the screening instruments should be sensitive, should be brief, shouldn't cost much, shouldn't require a lot of staff training, and should be consumer friendly. We have a publication out, Roger Peters, who was here yesterday. I hope people had a chance to sit in his session. He talked a lot about the evidence-based practice associated with substance use disorders and corrections, but Roger and associates have a screening guide which lists the instruments, and you can look through it. It's available via our website, and it gives you some sort of suggestions for what you might consider. There's no right instrument. There are instruments that are better or easier to use within your setting, depending on who you're screening and what the skills are. The goal is universal screening. If you don't look for it, you're not going to find it. It used to be in the old days that we said, oh, I don't want to screen for substance use disorders because then I might have to do something about it and I don't know what to do. That's not a very good strategy. That's the ostrich head in the sand strategy. Not likely to put people into the best places. So, universal screening. All individuals booked into jails screened for both mental health and substance use disorders. An old mentor of mine taught me that jail booking is actually a public health opportunity. There are many individuals that had not ever known that they had an illness or never sought help for it. And coming into those settings for the first time, they have somebody ask questions about it that could identify it, and then think about linking them to appropriate strategies going forward. So we want to have universal screening. Those that screen positive for behavioral disorders move forward into an assessment, which consists of gathering key information. It's a process, looking for collateral information. You know, jail and prison is a good time to be assessing folks for behavioral disorders, particularly co-occurring disorders, where there's a relative period of abstinence. And we can think about, okay, without drug and alcohol abuse, what are the signs and symptoms? What is their mood like? What's their behavior like? So we can get a handle on it. Doesn't mean that that will sort of carry over, that is, that abstinence when they're in community, but it's a good time to do that assessment. It typically involves a clinical examination and a look at records, and then most states require diagnoses to be made by licensed mental health professionals, typically a clinical psychologist or a psychiatrist, and more importantly, it's an ongoing process. So we want to assess, and this is a part of the case planning, their acute safety needs. We want to understand what their diagnosis is, what their disability is, where they fit into that quadrant I talked about, what level of care they might need. Most importantly, their strengths and skills that we could build on, the recovery support network, the cultural context they live in, their phases of change, stages of recovery as it relates to their progress from alcohol and addictive disorders. The best assessment tool that's out there, this is it. Doesn't exist. There's not a tool, okay? Sorry, it's a trick question. All right. It's a process, okay? You got to get the information, you have to do it in a longitudinal way, and you have to put it together to best address what their specific issues are, all right? We have a simplistic model of folks that move through our criminal justice settings, and I want to talk not simply about reentry at this moment, but give you some examples along the sequential intercept that moves from contact first on the street with law enforcement through their return to the community. Really, this is a circle, right? It's not a line. Unfortunately, it's a circle because many people end up revolving in and out and in and out and in and out. I want to talk about some of the innovations that are out there. You probably know of them within your community. There's a lot of attention to diverting individuals that don't pose public safety risks. So maybe you won't even have them in your reentry program because they wouldn't have penetrated deep enough to require those services on release. But the idea is you identify and enroll a target group. We've been talking about who the target group could be. And you link them to comprehensive and appropriate community-based services, and then you should get improved mental health, individual outcomes, and improved public safety outcomes. We're able to do the first stage pretty well because we can screen and assess and decide eligibility criteria for our program. The linkage to the comprehensive services is where things fall down. It's diversion to what is often the question that's posed, and that requires an inspection of your community and the development of those resources that are actually going to bend that curve, that recidivism curve. A lot of interest is in law enforcement. First contact on the street, public safety, paramount. They have a lot of decisions to make on the spot, and that we have developed in our communities a range of specialized police responses. So the most common one that you may be familiar with is the crisis intervention team. But there are other co-responder models and other ways in which these specialized responses get developed. The key is to improve services for those folks on the street with mental illness. We're not trying to create social workers out of police people, but we would like, when they end up on the scene and a person is in crisis, to get an outcome that sort of calms things down and move people to their appropriate setting, as opposed to stir things up and end up with a lot of bad outcomes. And these specialized police responses have been associated with improved efficiency, improved effectiveness. If you have a drop-off center for a policeman to go to, as opposed to jail and a booking sally port, that is something very welcome. That officer that goes to the ER and has to spend 4 to 8 hours waiting for medical clearance is not a happy camper, and they're not doing the work they were paid to do. They're not on the streets, all right? So when given that choice, 4 to 8 hours in the ER or 20 minutes at a sally port, I'll just book the person, and then they're back on the street. Again, we want to think about alternatives for them. These specialized police responses, like CIT, have been associated with reductions in officer and civilian injuries, improved officer knowledge. The CIT program requires 40 hours of training for the police officer to understand what mental illness is and how to respond to it. It's often done in association with family members in the community and the mental health system, and these are effective partnerships that have been associated with good outcomes. People move forward, end up in our courts, and that we have had the evolution of specialty courts. Many of you are familiar with drug courts, and there are almost 2,000 of them. We have about 300 to 400 mental health courts or dockets in our country in which there is this coordination and planning. They operate within a local context. There's informed choice, explicit terms of participation. People are given a choice. It's voluntary. You can come and before me, participate in my mental health program for a year or two as an alternative to being in jail, and presented in the right way with the consent of the public defender, they end up with very good outcomes if they select the right people. Okay, and when I say the right people, I'm saying that it doesn't help our jail day stays if we bring a lot of people with low-level misdemeanor offenses into our mental health court. All right, we need to be taking those individuals that are facing real time, that don't pose a public safety risk, and provide them an alternative to jail or prison. We have an evolving judges leadership group, 400 to 500 judges around the country that are interested in using therapeutic jurisprudence to improve outcomes for the defendants that come before the bench. The judges in your community are important leaders. They're great conveners, and they have the opportunity to move these issues forward. And it's really an important relationship to develop if you're going to end up with better behavioral health outcomes. Within our jail settings, there are a variety of services that can be provided. It is important as an outcome that we understand who within our jail have behavioral health disorders, and we can look at what their length of stay are. It is the case, as I showed you earlier, that lengths of stay are greater when you have a mental illness than not. People say, well, that's because people with mental illness have higher charges, okay, and they're facing longer time. Well, you need to know your length of stay data by charge. And Rikers Island in New York is going through the process of doing that assessment, and by every charge, it is clear that the lines on the right, the green lines, are larger than the lines on the left. Folks with mental illness are longer than folks without mental illness. And then calculate your recidivism rates. So if we're going to bend the curve, we got to know what our baseline is. And here we see that folks in this particular study, again, higher revocation rates. Can we do something about that? There's a lot of good work done within our prisons and in reentry, and that's what this conference is about, and this is what your work is, and this is what you know better than I. I'm just going to talk about a program that I visited in Wisconsin, opening avenues to reentry success funded by the state of Wisconsin, in which this group picked high-risk, high-need individuals, the toughest folks that had historically high recidivism rates. And in a program jointly administered by the Department of Corrections and the Department of Health Services, they've been able to provide both a pre-release program to help with their cognitive thinking in the 6 months before they're released, and then wrapping services around them on return. This has been up and operating for a couple years now. They've had 85 folks go through it. Less than 8% have returned at this point in time. It's possible to do. It's expensive. There's a lot of services. They include housing, treatments, meds, but it's a lot less expensive than they're staying within the prison at that state. In community corrections, and out on our table, this publication is there, we spent some time thinking about how can probation and parole improve outcomes for folks with behavioral disorders. And we talk about and looked at specialty probation, reduced caseloads, specific training, firm but fair relationships, and in this study what we see for those folks that were in specialty caseloads in green compared to the traditional caseloads in red, both the revocation and their arrest rates were significantly reduced. In Alexandria, another example of this specialized service, they have a probation officer that's gone through a lot of training, not excessive, but sufficient training, and that they use a compass as their risk needs assessment to target their resources in a high-risk, high-need group. They use thinking for a change, one of our cognitive strategies. They have motivational interviewing as a technique. Their relationships are firm but fair. They use problem-solving strategies, and they feel they don't have the evaluation data that I'd like, but their testimony is that this has made a significant difference for their cohort. So those are the type of opportunities, and those are the mechanisms for identifying a group and then linking them. What do you link them to? And I want to spend just a few minutes with you at this point in time talking about those comprehensive and effective services. Evidence-based practice. Probably the word with less meaning than maybe case management at this point in time. What is it? I mean, we all do it. Everybody's doing it. Oh yeah, I do EVP. Yeah, no doubt. Bring them here. It is got a definition. It's the integration of best research evidence with clinical expertise and patient values. It does have a science behind it, and there was a beginning of that discussion in the employment panel that preceded me. It starts with case studies. You know, Jim had X, I did Y, he seems to be better. Let's see if that works for John, all right? We build upon that, and we have a single pre-post test. They had these features before they did the intervention, we did it, and now there's some difference. Well, that's terrific, that's more evidence, but it doesn't sort of suggest that there's causation because we don't have a comparison group. So let's add a comparison group and move up the scientific pyramid, all right? And that we continue to move forward with sophisticated methodologies. It worked in the experimental group better than the control group. Does that work in some other community? Let's try it somewhere else. Does it work with some other set of features in the population? Let's try that. Well, let's look at all the studies that are out there in a meta-analytic review and see if this still hangs together as a particular practice that delivers the outcomes that we care about. And then maybe we'll bring a panel together in order to define the characteristics of an evidence-based practice. And then I left the tip of the pyramid off. That's the hand of God. She comes in and says, yep, that's an evidence-based practice, and it gets listed on our NREP or our crimesolutions.org or our reentry what works, so that there is a science behind this. There are limitations to our science. You got a program versus a technique. I do motivational interviewing. Okay, that's a good technique. That's an evidence-based practice. Is that going to have the same impact as providing a comprehensive case management structure? There are types and brands. I want to talk a minute about fidelity. There's a lack of generalizability depending on the population. We have a lot of research in non-criminal justice populations. Does it work for folks that have criminal justice backgrounds? And then there just isn't enough research, period. We don't have all the evidence-based practices we have for the conditions that you encounter on a daily basis. But we still need to use evidence-based thinking, all right? What does the existing research say that we might apply to this circumstance and hope to get a good outcome? But just saying you do EVP and actually doing an EVP can be two different things, and this is the issue of fidelity. And that it is important that if you're doing an evidence-based practice, that you do it the way the manual described it, with the features that are associated with those good outcomes. This is a slide I throw up to illustrate this point, why I care about fidelity. This is a review of over 30 assertive community treatment teams. Assertive community treatment is one of the most documented and validated interventions for people with serious mental illness. It was designed for those folks coming out of our state hospital, provides them 24/7 wraparound case management services, treatment on the team, low case loads, okay? And so this study was looking at teams in the pink line on the bottom that had low fidelity, and there's a fidelity measure for ACT, versus those with high fidelity on one outcome. And that is, this was just the outcome that I'm demonstrating here, the percent in remission. So of the 100 people that came into that ACT team, how many of them had 6 months of abstinence? And that what we see is that over time, those on the bottom curve achieved that degree of abstinence at the rate of about 5% per year. So of the 100 people at year 1, 5 were in that condition, 10 at year 2, 15, not always the same people, but that was the rate at which they achieved that particular outcome measure. That turns out to be no better than the natural history of substance use disorders. George Valiant did a study in Cambridge, looked at a group of individuals with alcohol dependence, followed them over time, and found that about 5% of the year quit because they were sick and tired of being sick and tired, or their job was threatened, or their marriage was going to dissolve, and they stopped. So if you're looking for a good outcome on an ACT team, but don't deliver it with fidelity, it's not any better than doing nothing at all. Now, I don't want you to take away do nothing. Let's look at the ACT teams that actually did with fidelity. They have abstinence achieved at the rate of about 15% per year. And that gap between the blue line and the pink line represents a whole bunch of morbidity and mortality, a whole bunch of jail admissions, a whole bunch of prison time. Okay? So we have to be on this fidelity curve. I also want you to pay attention to the x-axis, because those hash marks aren't visits, aren't probation appointments. Those are 6-month intervals. So in one of the best documented research interventions with fidelity, we still only get about 15% of our folks abstinent per year. I bring this up because on your reentry programs, with the folks you're working with, they will have had their substance use and or mental illnesses before they were a part of your program, and they will likely have them after your program. So what's your role? What can you do? Well, you have a very important role. You're not the be-all and the end-all, but you are part of a process of recovery with effective interventions, increasing the rate at which people move forward with these interventions, but you're always going to have to be mindful of a handoff, because I'm talking about conditions that are chronic and relapsing by definition. So when they're done with your intervention, who's going to continue the care? Where's the community partner that you have that's going to pick up where you have left off and keep moving the ball forward with that particular individual? We had an opportunity with some funding to bring together a group of experts to look at the evidence-based practices that work for individuals that don't have criminal justice involvement and think about their application to those that do. So this is a quick discussion about what do we link them to. And in a summary paper that we developed, we looked at these interventions. Housing. If you don't have a house or a place to live, it's really tough to do anything. It's tough to get your employment going. I work at a shelter in Charleston, South Carolina. I see the folks that struggle to make it to, they have to be up at 5, they got to be out at 6, they got to take all their stuff with them, they got to get to work, then they got to be back before 6, or they lose their bed. It's almost impossible to make that work. So housing is a critical element. It has data to support it. There is a session this afternoon with Andy McMahon from the Corporation of Supportive Housing that I encourage you to attend to. It's important that we address this issue. Integrated treatment. I mentioned it to you as the evidence-based practice for non-justice involved individuals. We have a growing body of literature that supports it for those with criminal justice backgrounds as well. They're the same people. They just happen to be in or out in some different setting. They still need that integrated care model. ACT, assertive community treatment, that's an interesting one. In the studies that were reviewed, the results were mixed. There were some that improved the criminal justice outcomes, but there were several studies of ACT that showed increased rates of incarceration and increased jail days. Huh? What's that about? Well, that's the same phenomena as the low-risk, high-risk discussion. If you put individuals on an intensive case management team and watch them closely, they're going to screw up. And at some point, they'll screw up and have to be reported. And at that time, it might be violated, and they may end up going back. So there is now the evolution of forensic assertive community treatment teams, which have a caseload that is 100% with criminal justice individuals with serious mental illness, oftentimes have a PO that are part of the team, integrated there. They then are able to make decisions about, okay, dirty urine came in, what do you think we should do? Well, don't necessarily need to put them in jail. Let's sort of increase the contact they have with their substance abuse treatment program, or a few more meetings. Let's think about the right response for this particular individual. And so these FAP teams are emerging as an evidence-based response to individuals. They're very expensive. They're very resource intense. And for that program in particular, you want to pick a high-risk, high-need group. You don't want to spend your scarce resources on people that aren't going to get the most impact from that intervention. Supported employment, we talked about that earlier. For folks with serious mental illness, they want to work and they can work. And as an evidence-based practice, if you put them to work at a competitive job and give them a competitive wage, they will, over 50% of them, succeed in that. But it's real tough to do if you have to attend your status hearing every 2 weeks in the mental health court. So there need to be modifications even to that evidence-based practice to allow for its application to these populations. Trauma interventions, trauma-informed care, 100% of the women that we interview have traumatic histories, many of which meet criteria for PTSD, almost the same percentage of men. We have to be aware of that and provide interventions that don't re-traumatize individuals, are sensitive to the issues that may be responsible in part for the behavior that got them in trouble, and assist them in working through those issues so that they can move forward in their recovery. Medications, very well documented as an effective component, tool of treatment, both medical assisted treatments for people with substance use disorders like methadone and buprenorphine, and in the treatment of mental illnesses with antidepressants, antipsychotics, and the like. All good, except who's going to prescribe, who's going to monitor, and most importantly, who's going to pay? Real expensive, right? And then lastly, there is the CBT. I'm not talking about any old CBT. I'm talking about the cognitive-based interventions that target criminogenic needs. And that's where we need to move. That's the next generation of services. That's where your partners in the community need to step up to the plate. These interventions like thinking for a change, reasoning rehabilitation, moral recognition therapy, all got a great literature as an evidence-based practice within criminal justice settings. Now we're trying to apply them to a group of individuals with serious mental illness and apply them within the community. And there is a literature evolving that says, 1, you can do that, 2, the people like participating, and 3, you get good outcomes with it. So that's where we need to move going forward. Any of these services, however, are not as good as an integration of services. And so we want to think about the collaborative opportunities between our correction systems and our behavioral health providers. This slide, developed by the Washington group, looks at outcomes, recidivism rates for adult offenders. I'll draw your attention to the drug treatment box. Looking across a variety of studies, good drug treatment dropped recidivism rate about 12%. But drug treatment combined with intensive supervision dropped recidivism rate by 22%. So how can we bring together our science? How can we bring together our systems to serve those individuals that have needs in each? It's doable. I've given you some examples of it, and I'm sure you're in your communities about it. In summary, we got to screen and assess. If you don't look for it, you won't find it. An acronym: be fair, focus resources on high-risk cases, address those criminogenic needs, implement evidence-based practices, and be responsive to that individual variation. And lastly, monitor outcomes. I want to end my formal comments with this. It's not a research finding. It just happens to be a belief, and I think we share it. And this was at my medical school graduation from a medical school speech that was given in 1925. One of the essential qualities of the clinician is interest in humanity, for the secret of care of the patient is in caring for the patient. And you can substitute client, ex-offender, guest, neighbor, whatever you'd like into that sentiment. However, it is the basis of our success, a relationship that is based on mutual respect. And I thank you all for providing that to the people you come in contact with, and I hope the rest of the conference fulfills some of our expectations to move these issues forward. Thank you. So we have time for questions or comments at this point. We have a microphone that's roving around the room. We have stomachs that are growling for lunch. A lot of competing demands here, but if there are some questions or comments, We would love to entertain them at this time.
Hi, thanks for a great presentation. I'm wondering about the assessment at the front end of individuals who present with mental health or substance abuse disorders, and what discretion that leaves to corrections officials to, say, oh, well, this guy doesn't appear to have a problem, it doesn't present with any problems, and therefore he's not going to be screened. Is that a concern, or what kind of efforts are made, ideally to prevent that kind of discretion from leaving people out? Well,
it depends again on what setting you're referring to, but let's think about bookings into jail or movement into prisons. There are constitutional protections which include the treatment of behavioral disorders for those folks that are within those settings. So it's a requirement that people get screened and assessed. Does it happen all the time? No, I know it doesn't, but it is a part of providing a basic standard of community care. The issue around, well, I know who is and who isn't, or that guy doesn't seem to be a problem, we're really bad at guessing those things, okay? And that when we use our gut instincts, we're going to be probably no better than flipping a coin on some of these issues. And that it is actually sometimes the most quiet, less kind of out there in your face person that has the most significant disorders, the folks that are just kind of tucked away. The suicide rates that we have within our correctional settings are astounding and high. And so screening and assessment is really part and parcel of conducting your constitutional requirement to provide adequate care. I understand that there are resource issues involved in that, but the screen, the brief gel mental health screen that I showed you earlier, that's 8 questions. It's delivered by correctional officers. It takes under 2 minutes, and that it answers the yes/no question and sends back about 25% of people that then require an assessment. All right, that's a chunk of folks, but it's not everybody. And so the whole point of screening is sort of to triage and narrow this funnel down so that some of the issues you've raised aren't so much of a pressing concern for the facility manager. I can't assess everybody. Don't need to. Screen everybody, assess those who are positive, and develop a plan related to those results. Thanks. Yes, sir. In the back. This is a challenge for our microphone carrier. Yeah. Maybe if you're on the edges, if you could move to the centers, but yes, sir.
Good morning. I have a question. I'm with the Cuyahoga County Office of Reentry in Cleveland, Ohio. I'm the program director. And one of the things that we've been advocating very strongly in Ohio, and the Ohio Department of Rehabilitation and Correction has been very receptive, is when an individual gets released from prison, that he has a behavioral health diagnosis. Historically, we had like a 2-week period where they would have a prescription for their medication. Now we're moving into at least 30 days. So there's been receptivity on the Ohio Department of Rehabilitation and Corrections to address this issue and the need. What can we do nationwide, for lack of a better term, from an advocacy standpoint, to really look at the issue? Because even the 30 days is still a challenge as it pertains to that individual who's in need of medication. Yeah. Thank you.
No, medication continuity is critical, both on going into facilities, but as you're discussing specifically on reentry into our communities, and that the goal obviously should be continuous medication from the point of release until they get their first appointment for it to be reevaluated, and as is typical, for it to be re-upped. That varies in terms of the lag time between release and appointments. On the reentry prep side, we want to identify those folks that are going to have that need and coordinate that appointment ahead of time. So if you know in your community it's 3 months to get in to see a psychiatrist, then you want to 2 months before the person's released start making those appointments. As an advocacy point, it is critical. Those periods, as we've heard over, there's a critical time at the point the person leaves the facility that supports and services be in place, and medication for those with diagnosable conditions is a key component of that. So local advocates within your states, like the National Alliance for the Mentally Ill, can be very helpful in sort of making the case. And then we can work with our pharmaceutical companies to think about some of the free programs that are out there. There's a lot of programs that folks without resources can access online and get subsidized medicines or free medicines for a period of time. But I think the issue needs to be sorted out systemically now, not at the point the person is trying to move into the community. So thank you very much for raising that.